All right. Good afternoon, ladies and gentlemen. For those of you who don't know me, I'm Nate Cruz. I'm an assistant professor of criminal justice at Penn State Altoona. Today, I'm going to be sharing findings from a paper that I published with my friend and colleague at Rand, Dr. Dick Donahue. In that research, Dick and I were interested in looking at provider-based stigma toward opioid users held by law enforcement officers. And since we published this paper, we've published a couple other papers, so I feel it's important to talk about some of those main findings too, and how they tie into this paper here that Dick submitted for this conference. So I'm going to try to be as concise as I can today. I'm going to start off by giving you all with some background information on the prior research that's been conducted in this area. Then I'll move on. I'll talk about our methodology, some of the findings for this paper here that Dick submitted, and then some of our subsequent findings. And lastly, I will conclude by tying all this research together and talking about some of the implications from these findings. Ladies and gentlemen, we are currently in the middle of what the CDC has labeled an opioid epidemic. Our best estimates suggest that there are about 4.2 million Americans who use an opioid every day that they do not have a prescription for. And there are about another 950,000 active, meaning daily users of heroin. Looking at overdose deaths, we've been up around 50,000 for about the last 5 years now, and we actually have research that suggests that throughout the COVID pandemic and the lockdowns associated with it, that number actually increased last year. There are more Americans killed from opioids than there are from any other types of drugs. In fact, there are now more Americans killed annually from opioids and heroin than there are in car crashes and there are from firearms. So this is a very serious public health problem. The criminal justice system has also been forced to respond to this problem. If we look at arrest data, looking at FBI arrest data for the last 5 years, typically the largest category for which there are the most number of arrests is this category that they used to label quote unquote drug abuse violations. I don't like that term, but it's their term. If you look within this category, we see that about 1/3 of all these arrests involve either prescription opioids or heroin. Looking at our correctional populations, estimates suggest that about 1 in 5 inmates was an active user of prescription opioids or heroin before they were incarcerated, and about 1 in 3 report some type of lifetime dependency to these substances. So this is also a serious problem that is having effects on our criminal justice system. The picture on your screen describes or displays drug overdose death rates by states. And what you'll notice is that this epidemic seems to be disproportionately impacting the northeastern and midwestern regions of the United States. And this is important for our study because we actually looked at perceptions of police officers in Pennsylvania. And I believe in 2019, Pennsylvania was ranked 3rd in terms of opioid related overdose fatalities. The responses for this epidemic have been a little different than the responses that we've seen for other drug epidemics. We've taken more of a harm reduction approach in the system. We see officers and other first responders carrying and administering naloxone. We see drug courts and community correction centers implementing and using medication-assisted treatment, which involves combining traditional talk therapies such as cognitive behavioral therapy with opioid replacement medications such as methadone, buprenorphine, and naltrexone. We've also seen law enforcement agencies implement what we call deflection, LED, or warm handoff approaches in which they help facilitate a handoff to a treatment provider instead of taking a more punitive response to drug addiction, drug use. While all of these strategies are evidence-based, meaning that research shows that they are effective ways to help fight this epidemic, there hasn't been universal adoption of these policies. In fact, our best estimates suggest that between 1 in 4 and 1 in 5 law enforcement departments across the nation have a policy that require officers to carry and administer Narcan. Less than half of all drug courts permit participants to use opioid replacement medications. Less than 5% of all incarcerated inmates have access to some form of opioid replacement medication. And in terms of deflection, our best estimates suggest that only about 10% of all police departments across the country are using some form of a warm handoff. Researchers from Johns Hopkins, Harvard, and the National Academy of Sciences have argued that one of the reasons why we probably haven't seen universal adoption of such policies is because of stigma. And they argue that stigma is one of the biggest barriers that we need to overcome to fight this epidemic. So what is stigma? Stigma is really an amorphous term. The word itself originated from an ancient Greek phrase that referred to a mark that was placed on the forehead of unruly slaves. For the purposes of this study, Dick and I define stigma as social ostracism or marginalization of persons who have or exhibit a socially undesirable attribute or characteristic, such as being an opioid user or someone who uses heroin. There are many different types of stigma. Our research is most concerned with social stigma. And social stigma refers to the actual attitudes, beliefs, and actions held and made by members of the general public toward a person who has one of these undesirable attributes or characteristics. Within social stigma, there are 4 different variants or 4 ways in which it has been measured in the scholarly literature. And these variants include perceived dangerousness, blame, desires for social distance, and fatalism. Perceived dangerousness is the belief that persons who use prescription opioids and heroin are somehow a threat to the safety of themselves and a threat to the safety of the community. Blame refers to this belief that someone who uses prescription opioids and heroin is somehow responsible for any problems that are associated with it, or they're responsible for not being able to overcome a dependency issue if they do have one. Social distance, unfortunately, is a term that we've all become familiar with in the last year. This refers to a desire to place tangible distance, physical space between oneself and persons who use prescription opioids and heroin. Fatalism is the belief that drug use, that persons who use prescription opioids and heroin in this case, somehow have an intractable condition, one that they cannot overcome, and they're always going to be confined to a life of addiction if they are dependent on these substances. Despite all the talk about stigma toward drug use in the scholarly literature, before Dick and I published this paper, there really hadn't been much research that had examined what we call provider-based stigma toward persons who use prescription opioids and heroin. So what Dick and I wanted to do is we wanted to examine provider-based stigma, which is just social stigma in a provider-based context, someone who has to provide treatment to a marginalized group, such as those who use prescription opioids and heroin. We wanted to examine this concept among law enforcement officers. And additionally, we wanted to look at the predictors of this stigma, or when we say predictors, we mean predictors in a linear sense, so the correlates of this stigma, and then examine the relationships between stigma and attitudes related to the use of medication-assisted treatments, Narcan, and attitudes related to the behavioral responses or anticipated behavioral responses of first responders. And the paper that Dick was going to present today is this paper right here that was published in December in the International Journal of Police Science and Management. So I'm going to first talk about this piece, and then I'll discuss some of our subsequent findings that are related to this project and are important that I think you guys should know. If anyone wants a copy of this paper or any of the other papers I'm going to talk about here, shoot me an email. I'm happy to send those over to you as soon as we're done here today. So looking at the sample for that project, we collected self-report survey data from 208 law enforcement officers working for 42 different police agencies across the Commonwealth of Pennsylvania. And we used a reusable Qualtrics link as a way of collecting this data. And we recruited these professionals through professional law enforcement organizations and by contacting police chiefs directly. In terms of measures, our key dependent measures are original measures that we created using these concepts that we found in the stigma of mental health literature. Dangerousness was a 6-item scale, blame, 3-item scale, social distance, 6-item scale, fatalism, another 3-item scale. The specific operationalization of these variables is defined in those papers. If you want more information on that, I'm happy to share that with you. Just know that they were reliable, they were valid measures of these concepts. Looking at our independent variables, we looked at officers' beliefs about addiction. Did they support the disease model of addiction? Did they think that someone could become physically dependent on these drugs or not? We also examined beliefs about drug users. And here we were trying to look at the intersectionality between stigma of persons who use opioids and beliefs related to the demographic characteristics. So do you associate drug use with minorities? Do you associate it with someone who is unemployed? Do you associate it with someone of low SES? And then we had a host of control variables. Looking at some of our key findings, I want to direct your attention to the stigma variables down here. What this table shows really is that the law enforcement officers in our sample held relatively high levels of these different variants of social stigma, notably perceived dangerousness, blame, and desire for social distance. They held less fatalistic beliefs. So what this means is that the officers in our sample, in the aggregate, perceived persons who use opioids, prescription opioids and heroines as being fairly dangerous. They tended to blame them for using these substances and all the problems that were associated with it and not being able to overcome their dependency issues. And they did not want to be around them in social settings, in non-work settings. However, they did not believe that this condition, if they were somehow dependent on these drugs, they didn't think that they would be confined to a life of addiction. They thought that there was a chance they could overcome it. We've since collected data from other samples as well, and I can say that the law enforcement officers in our sample held higher levels of every variant of social stigma that we measured than did the students that we have sampled. They held less stigma than did the EMTs and the paramedics that we've been sampling. Looking at some of the predictors of these beliefs, some key findings that we find across models are that typically it's older officers that hold less stigmatizing beliefs. And this is self-report data, so there are limitations with that. But as you go up in rank, as you increase years in auxiliary models, we see levels of stigma decreasing. Looking at beliefs about addiction, if an officer believed that drug dependency, if they associated that with this medical model of addiction, they placed less stigma onto opioid using persons as measured by perceptions of blame and perceptions of fatalism than those who did not support this belief model of addiction. And then when we look at the intersectionality here between other biases, we find that officers who associated drug use with being predominantly among those in the lower class and those who were unemployed also perceived opioid using persons as being more dangerous. Looking at some of our subsequent projects, we've published, I think, 4 or 5 papers off of this now. What we found, as I said, is that officers do hold higher levels of stigma than students that we sampled, but they hold lower levels than EMTs and paramedics that we sampled. When we look at the relationship between these different variants of stigma and attitudes toward harm reduction, we find that there's an inverse relationship, that as stigma increases, perceptions, positive perceptions, that is, of Narcan tend to decrease. Positive perceptions of MAT decrease. That officers who stigmatize these vulnerable groups don't think that they should be using Narcan. They don't think that we should be using MAT in the justice system. Perhaps most importantly, though, we found that stigma does predict the anticipated on-duty responses of officers and EMTs, that those who stigmatize these groups of people, as measured through having high levels of those 4 variants I just went through, they tend to be less willing to provide a full range of services to someone who uses opioids, someone who suffers or experiences an opioid overdose. What is promising, though, is that training experiences seem to influence these relationships both directly and indirectly. So those who have more training and those who have better training have less stigma, more positive attitudes toward Narcan, more positive attitudes toward MAT, and they're more willing to provide a full range of services to overdose victims. So collectively, what do we think is going on here? We think that there's some type of a labeling effect that is influencing first responders' responses to opioid overdoses, if you will. And essentially, what we believe is happening is that if a first responder associates this label, being an opioid user, someone who uses heroin, if they associate that with those stigmatizing attributes that I just talked about, dangerousness, blame, fatalism, that can influence their perceptions of treatment, their perceptions of Narcan, and their perceptions of MAT. It can also influence their desire to want to place tangible space between these people in social settings, for a desire for social distance, which in turn, unfortunately, as we found, influences their occupational responses. And there is some conditioning effects that go on here. If there's a departmental level policy related to the use of Narcan, related to the use of different medical practices, that influences the models. Their own innate biases toward persons of color, towards or beliefs about drug use in general can influence this model as well too. So there are some conditioning variables. And since Dick and I published that first paper that he was going to talk about today, we've attempted to analyze this model using path analysis, and we do find support for it. We found that officers, first responders, EMTs, paramedics, who hold these stigmatizing attitudes toward opioid and heroin use, that in turn does lead to negative perceptions of treatment, desires for social distance, and then in turn that leads to these populations being less willing to administer Narcan and provide medical assistance to persons who suffer opioid overdoses. So what are the implications of all this work? Well, theoretically, this does provide support for this labeling effects model that we have developed. In terms of practical implications, though, it suggests that there may be a possible need for stigma reduction campaigns for actors within the system and for students, those who want to go into the system. And the best forms of stigma reduction campaigns that we know of right now are these contact interventions, where we get persons who have struggled with substance use dependency and have overcome these issues. We get those in contact with first responders, have them share their stories, increase familiarity. There does seem to be positive effects from those types of interventions. We also recommend that officers and students in criminal justice programs in particularly should have more training on substance use addiction, particularly with a focus on the disease model for addiction. Through our research, we actually found that no criminal justice department in the Commonwealth of Pennsylvania required a course on substance use dependency as part of their normal course curriculum for graduation. And that's a serious problem, because these are students who are going to go work in the system. They're going to work around persons who struggle with drug use issues, who have mental illness and things like that. So they should probably receive more training in the classroom on these types of issues. Then we also want to highlight the importance of departmental policy. As I said, having a departmental policy related to Narcan, related to medical assistance, related to overdoses, officers listen to policy, and our models support that they're more willing to provide help, even if they have all these biases, if the department has a policy. Unfortunately, most departments don't have such policies today, so we encourage more departments to adopt such a policy. In the future, we're looking to expand this to other locations and to look at other treatment providers in the system. And I've included both my email and Dick's down here. If you guys have any questions, feel free to email us directly. As I said, I'd be happy to send you any of the papers that we've published off this data. Thank you.
Great, thanks, Nate. Hi, everyone. Oh, first, could someone please just let me know if you either can't see the screen or if I've accidentally shared my notes. My name is Kate McLeod. I'm a PhD candidate in the School of Population and Public Health at the University of British Columbia. And on behalf of my co-authors, I'm happy to be here today to tell you about our study looking at the use of community outpatient healthcare services and risk of overdose in the weeks following release from incarceration in British Columbia. First, we want to acknowledge that the authors on this project live and work on the unceded territories of the Coast Salish peoples. This includes the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. We would also like to gratefully acknowledge the organizations that made this work possible through data sharing, among many other supports. And finally, personally, I would like to acknowledge a fellowship with the BC Ministry of Mental Health and Addictions that allowed me to do this work, that was supported by the Canadian Institutes of Health Research Health Systems Impact Fellowship. So a large body of evidence has demonstrated that the weeks following release from incarceration are a period of high risk for overdose. We also know that one of the contributing factors to this elevated risk is interruptions in healthcare, which are quite common when people are transitioning between correctional facilities and the community. In Canada, people who have been sentenced to less than 2 years or who are remanded to custody to wait for their trial or sentencing are held in provincial or territorial correctional facilities. This is as opposed to federal facilities, which hold people who have been sentenced to more than 2 years. So this means that on average, people in provincial correctional facilities are there for a relatively short period of time and instead tend to cycle in and out, which can create challenges in providing healthcare and in establishing appropriate links to community services. To better support continuity of care between correctional facilities and community healthcare services, in 2017, British Columbia transferred responsibility for healthcare in corrections from a private for-profit healthcare provider to the Ministry of Health. So many studies have looked at fatal overdose in the weeks following release from custody, but there are a few that have examined the risk of non-fatal overdose. None, to our knowledge, have looked at access to primary healthcare services as a factor in the risk of overdose during this acute period of time. So the primary aim of this study was to look at the relationship between use of community outpatient healthcare services and subsequent non-fatal overdose in those first 30 days after release. As a secondary aim, we looked at the relationship between this use of community outpatient healthcare services and fatal overdose in this same 30-day period. To do this work, we used the British Columbia Provincial Overdose Cohort. So the cohort was created to inform response to the overdose epidemic that was declared a public health emergency in British Columbia in 2016. The cohort includes a random sample of the BC population. It's about 20% of the population, about 1.1 million people. And the cohort links specific health and social administrative data, so things like physician visits or hospital admissions at the individual level. And it can do this using a unique identifier that's assigned to all BC residents as part of the system of universal public health insurance. So we looked at releases from provincial correctional facilities that had been captured in this random sample. And we looked at releases from continuous sentences between January 1st, 2015 and December 1st of 2018. We excluded incarceration that lasted less than a day. and where time in the community after release was less than a day. We identified use of outpatient healthcare through physician billing records, which are also generated as part of the public healthcare system. So these are not physicians. So this is our proxy for primary care. It's predominantly physician visits that are unrelated, for example, to hospital admissions or emergency departments. Non-fatal overdose were identified using ambulance and emergency department records. And finally, fatal overdoses we identified using BC Coroner Service and the Vital Statistics Agency data. In our study, we found that 3% of releases were followed by an overdose within 30 days. In this time, 90% of deaths in this month following release were due to fatal overdose. So this is consistent with other studies that have found fatal overdose to be the leading cause of death among people with a recent incarceration history. Importantly, in most releases where there was a non-fatal overdose in those first 30 days after release, the person had had at least one physician visit prior to the first non-fatal overdose that occurred during follow-up. Less than half of people who had a fatal overdose had access to outpatient healthcare after their release. So we then looked at the relationship or the association between outpatient healthcare use and risk of non-fatal overdose using an Anderson-Gill regression model. So during follow-up, there were 566 non-fatal overdose events. Importantly, we used a time-varying measure of outpatient service use so that in this model, people classified as having access to outpatient care had at least one visit prior to the overdose event. So this regression model adjusted for confounders and risk factors that we know from the literature, things like age, sex, number of days of most recent incarceration, and number of previous provincial incarcerations. We also adjusted for lifetime receipt of social assistance, having received opioid agonist treatment during this incarceration, and whether or not the release occurred after healthcare services were transferred to the Ministry of Health. We found that having accessed outpatient services was associated with having a subsequent healthcare-attended non-fatal overdose. We conducted a sensitivity analysis for the year of release to account for changes in the drug supply, but this didn't significantly affect the estimate. We also looked at effect modification of age on use of outpatient healthcare services and found that this positive association existed for all age groups. We also looked at the 31 fatal overdoses that occurred during follow-up. We used a standard Cox regression to examine this relationship. In this model, because non-fatal overdose is a known risk factor for fatal overdose, we also included adjustment for previous non-fatal overdose events, which included those that occurred during follow-up prior to the fatal overdose. In this adjusted model, we found that people who had engaged with outpatient healthcare services had a reduced hazard of fatal overdose. Finally, we found that most people do not access primary healthcare services within 30 days after release. In this study, we found that 60% of women and 67% of men did not have any physician billing records for those first 30 days. However, we also found that the proportion of people who accessed healthcare after release increased after the transfer of healthcare services to the Ministry of Health. So research is needed to better understand this change, but it is a promising direction. So in terms of what this means, a limitation of the study is that we were only able to identify overdoses that were attended by emergency healthcare services. However, the use of outpatient healthcare services was associated with having a medically attended overdose, and it may mean that people who are engaged with healthcare for other reasons may be more likely to access medical help during an overdose event. It might also be that people engaged in healthcare are more likely to engage in harm reduction services, such as safe consumption sites. So increasing connection with community health and social services during this period of increased risk during the transition from custody to community may help to reduce harms, morbidities, and mortality from overdose during this period. There's a need for greater understanding of how models of governance shape continuity of care and integration with community healthcare services, and also a need to understand and address barriers that prevent so many people from accessing healthcare services after release. Finally, what we learned is that 73% of people who had a non-fatal overdose had an outpatient healthcare visit prior to their first overdose during follow-up. This can mean that primary care providers could be a key point of intervention and support. Providers should be trained and resourced to offer comprehensive prevention and treatment supports to people with a recent history of incarceration. Thank you.
Okay, so I'm not currently seeing any questions in the Q&A, but if anyone, we have a few more minutes here. If anyone has any questions for any of these presenters, you can put it in the Q&A, or you can raise your hand and I can let you voice your question yourself. So we can wait a few minutes for those. I'm gonna take that to mean that you all presented your study so clearly that no one had any follow-up questions. But as most of the presenters have said, they seem to be happy to answer any follow-up questions by email if anyone should have any. So I believe that concludes this panel for today, and I thank you all for your time, presenters and audience alike.
Thank you.
Thank you.